Imagine you are on your neurology rotation when a 35-year-old man is brought to the emergency department. He complains of progressive muscle weakness that started in his legs and has been ascending over the past week. He also mentions tingling sensations in his hands and feet. 2 weeks ago, he had a bout of gastroenteritis. This, my friends, is a classic presentation of Guillain-Barré Syndrome or GBS. Let's break it down for your exams. Key clues in the question stem: ascending paralysis, recent history of infection, often respiratory or gastrointestinal, symmetric weakness, areflexia, absent reflexes, paresthesias, tingling sensations. Now, how do we differentiate GBS from other conditions with similar features? Transverse myelitis can cause similar symptoms, but it typically has a clear sensory level and often affects bowel and bladder function. GBS usually spares these functions until late stages. Botulism might cross your mind, but it classically presents with descending paralysis starting from the cranial nerves. Tick paralysis can mimic GBS, but look for a history of outdoor activities and the presence of a tick on physical examination. Let's talk pathogenesis. GBS is an autoimmune disorder where the immune system attacks peripheral nerves. It's often triggered by a preceding infection, commonly Campylobacter jejuni, which leads to molecular mimicry. The body's antibodies, meant to attack the pathogen, end up targeting components of peripheral nerve myelin or axons. For diagnosis, your first-line investigations should include CSF analysis. This typically shows albuminocytologic dissociation, elevated protein with normal cell count. Nerve conduction studies. These often reveal slowed conduction velocities or conduction blocks. EMEDs can help confirm the diagnosis and determine the subtype of GBS. Remember, in early stages, CSF protein might be normal, so don't rule out GBS if the clinical picture fits. First-line treatment for GBS includes supportive care. This is crucial. Monitor respiratory function closely, as some patients may require ventilatory support. Immunotherapy, either intravenous immunoglobulin EVIG or plasmapheresis. Both are equally effective, so the choice often depends on availability and contraindications. Deep vein thrombosis prophylaxis. These patients are at high risk due to immobility. Now let's recap the common presentations. Symmetric ascending weakness usually starts in the legs and moves upward. Areflexia, that is absent deep tendon reflexes. Paresthesias, that is often described as tingling or pins and needles. Facial weakness can occur in up to 50% of patients. Autonomic dysfunction, this can lead to issues like blood pressure fluctuations or cardiac arrhythmias. Respiratory compromise, in severe cases, this can necessitate mechanical ventilation. Remember, the course of GBS can be rapid, with maximal weakness often reached within 2 weeks. However, most patients begin to recover within 4 weeks of symptom onset. For your exams, always consider GBS when you see a case of rapidly progressive symmetric weakness, especially with a recent history of infection. Don't forget to assess for respiratory compromise and autonomic dysfunction, as these can be life-threatening complications. Good luck with your studies, future doctors. Remember, recognizing GBS quickly can make a significant difference in patient outcomes.